Hello, I'm Norman Swan. Welcome to this programme on chronic kidney disease, a silent condition. It's often preventable and it's said to be silent because up to 90% of kidney function can be lost before symptoms are evident. With ageing and the diabetes epidemic, more and more Australians are having a dialysis or transplantation for end-stage kidney disease. 1 in 7 Australian adults over the age of 25 has some degree of kidney disease, and chronic kidney disease constitutes nearly 10% of all deaths and more than 1.1 million hospitalisations. It's common amongst Indigenous Australians, who are 6 times as likely as other Australians to be receiving dialysis or to have had a kidney transplant. Death rates from chronic kidney disease are between 7 and 11 times higher in Indigenous men and women compared to non-Indigenous Australians. This programme is going to emphasise the need for a targeted approach to prevention, detection and the management of people with chronic kidney disease. It also examines the need for early detection and the delivery of chronic kidney disease care, which is not necessarily straightforward, with a specific focus on Indigenous and rural populations. As usual, there are a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. But now let's meet our panel. David Harris is a nephrologist and Professor of Medicine at the University of Sydney. Welcome, David.
Evening.
Tim Matthew is the Medical Director of Kidney Health Australia. Tim.
Evening, Norman.
Paul Snelling is a renal physician at Royal Prince Alfred Hospital in Sydney. Welcome,
Evening.
Paul. Beres Joyner is a GP and a specialist in public health medicine and is based in Rockhampton in Queensland. Welcome, Beres.
Good evening.
And Anne Blong is currently the chronic kidney disease nurse practitioner for Townsville Health Service District. Welcome, Anne.
Thank you.
Many nurse practitioners around in Townsville?
About 11, I think.
But we have 11. I thought it was probably more than I thought there were in the whole of Australia. So
They're not all doing chronic kidney disease.
And last but not least is another nurse practitioner who's Leslie Salem. Leslie is a nurse practitioner for the Integrated Chronic Care for Aboriginal People programme in Hunter New England Health. And Leslie is a descendant of the Woronora Nation in New South Wales. Welcome. Welcome, Leslie.
Thank you very much, Norman.
Leslie, tell me about the impact you see of chronic kidney disease on Aboriginal communities.
It's a two-edged sword here in New South Wales. I see the overall incidence and prevalence across Australia as being very high. I think in New South Wales, because of the vast distances, we have large areas of large groups of missions, small towns that have no GP services or very limited GP services. So I think we have poor recognition, and we underestimate the impact in New South Wales of kidney disease and the consequential cardiovascular disease on Aboriginal people.
What personal and family impact and community impact do you see?
Personally, I have a father who never smoked or drank and still had a heart attack at 49, so I guess I've always been quite passionate about health of Aboriginal people, but I've been working in nephrology for 26 years, and what I see is a lot of Aboriginal people not coming to the major town centres when they're referred for treatment of kidney disease. So I think there's a paucity of treatment going on in rural and remote areas.
Anne, do you agree?
Yes, I think that sometimes remote Aboriginal people don't attend hospitals because they see it as some place that you go if you're going to die.
What are we talking about here, Tim? What is chronic kidney disease? Is it one disease?
Well, we talk about it as though it was one disease. In truth, there are several or many different types of diseases which cause damage to the kidney, but it's a useful concept to consider chronic kidney disease as an entity defined as either a reduction in the efficiency of the kidney or the presence of kidney damage as evidenced by abnormalities in the urine.
And causes, David?
The most common cause in Australia and worldwide now is diabetes, and number 2 is glomerulonephritis, and number 3 hypertension.
Glomerulonephritis?
Yep, different varieties. IgA disease the most common.
And in Aboriginal communities, Paul, what's the commonest cause?
Oh, increasingly it's probably diabetes or a metabolic syndrome, but that's a bit simplistic in some ways. Our thinking is it's probably a whole-of-life disease in many ways, from early childhood damage right through to accumulating risk factors as one ages. So I don't think it's as simple as saying one disease. It's a whole-of-life story.
And of course, Beres, what we miss with chronic kidney disease is the impact on the heart.
Most certainly. I think I see chronic kidney disease as being a very important risk factor for cardiovascular disease. And while I think chronic kidney disease is important as a singular concept, I think it's most important that we actually consider it as one of the vascular risk factors.
Do you think that's generally known, Anne?
No, I don't think it is. I think people think that if they've got kidney problems, then they probably have diabetes, and if they get that under control, there's no other problems. But I think even early chronic kidney disease causes 10 to 20 times the cardiac risk factors.
Do we know why, Paul?
It's certainly through accelerated cardiovascular disease the risk comes, and it's probably through both an association with kidney disease being accelerated by vascular risk factors, hypertension, diabetes, hypercholesterolemia, but also with reduction in kidney function. There are probably other changes that affect blood vessels, changes in inflammation, oxidant stress, changes in the different lipid profiles and so forth.
But it is an independent risk factor?
An independent risk factor, yeah.
How strong an independent risk factor, Tim?
It's probably about as strong as cholesterol. Probably increases the risk by 3 to 5 times, depending on how you assess it and look at it. It is one of the necessary preclusions to using the new absolute risk tool assessment. You must measure kidney function first, because if you have a reduction or you have some important CKD, you shoot to the top of the tree as a high-risk person.
So how much of it is around, David?
Well, chronic kidney disease is, in fact, a very common disease, and it's not recognised how common it is. So 1 in 7 Australians have some evidence of chronic kidney disease, and up to 1 in 3 Australians are at risk of having chronic kidney disease in the future.
So that's a substantial proportion.
Yes,
and getting bigger. And so the contribution of ageing and type 2 diabetes?
Well, as I mentioned, type 2 diabetes is the commonest cause in Australia and worldwide, and it's now over 30%, getting up to 40% of cases are due to type 2 diabetes. And certainly ageing does contribute a lot, and one of the difficulties in this area is distinguishing ageing, the normal ageing, from abnormal ageing of the kidney.
Tell me more.
Well, as you get older, your glomerular filtration rate declines with age, and so it becomes difficult to know whether a reduction in GFR in the older age group is just part of the normal ageing process, or whether that patient in fact has chronic kidney disease.
And what other risk factors, Tim? Because people talk about smoking.
Yes, there are 7 risk factors which we would like everybody to be aware of, and they feed into those who need to have kidney tests done, so they're very important. Smoking, obesity, family history of kidney disease, anyone with diabetes, anyone with high blood pressure, anyone who's over the age of 60, and anyone, of course, who's an Aboriginal or Torres Strait Islander.
So they are people who merit what screening?
They merit, according to all the guidelines in the Red Book and every way you look at it, a kidney health check, probably on an annual or a biannual basis.
Beres, what do you understand by a kidney health check?
I'd actually wrap it up again in a health check looking at cardiovascular risk factors, but specifically looking at the kidneys, we're looking at an eGFR and also looking at a urine test, and in general practice setting, if you can get at a dipstick urine looking for protein or blood.
Now, we've just done a series of programs on diabetes, and they raised the sign of the cross to the idea of doing dipsticks, that this is unreliable, not a way of measuring kidney disease, you might as well not bother.
I think there'd be some differing opinions on that, but I think that one of the challenges in general practice is actually getting a urine test in the clinic at the time at which you require it.
Anne, what's your view on that?
I think people find it very difficult to give you a urine sample on demand.
Paul, what's the evidence here? There's not much point in doing a test if it's not going to be worthwhile.
If it's not going to change your management or tell you something. Yeah, look, certainly for diabetes, the guideline is to quantitate albuminuria, with albuminuria being the marker of damage in the glomerulus. Proteinuria has a few other bits and pieces that slough off along the way, so albuminuria is better. For the general population, I mean, that guideline's not there, but it's useful and easy to do, and in fact, in America and other countries, as Tim might say, that albuminuria has been integrated into their cardiovascular risk algorithms as well as a marker of vascular risk, probably because the glomerulus is a blood vessel, it's a filter, and damage in that reflects damage elsewhere. I personally think a quantitative albumin or something along those lines gives you at least a number that allows you to stratify risk, and we know that if it's significant and you can regress that, it actually will allow you to tell your patient there's a better outcome.
Leslie Salem, what's your practice in Aboriginal communities?
Even though the focus for me is identifying kidney disease, I approach it as a cardiovascular risk assessment. So, one, I'm looking at how many non-modifiable things they have wrong, you know, age, Aboriginality, family history, gender, things like that. And for Aboriginal people, of course, the age is lower. And then I look at the modifiable things that I can actually deal in remote or rural areas: smoking, dyslipidemia, hypertension, diabetes, abdominal obesity, very important, psychological factors that may inhibit them taking on management or treatment, nutrition, lack of daily vegetables or fruit, alcohol intake, physical activity, microalbuminuria, of course, and then if they're in later stages, I look at anemia, any sort of vascular calcification, looking at ECGs and that, and any metabolic bone disorder or any inflammatory problems. So they're probably the key things that I'm looking at in assessing, either identifying initially or following through. I think even though it's kidney disease, I'm looking at constantly looking at cardiovascular risk. And what can be modified. And
how easy in the environment of an Aboriginal community is that to do? I mean, that's a long list of stuff.
A lot of that is point-of-care testing, so ACRs or HbA1cs on point-of-care testing. I just need a couple of drops of blood and I can do lipid panels, hemoglobins and that. And I had to base the practice on point-of-care testing, portable ECG equipment that can be used under a tree with a laptop, things like that, because one of my clinics is actually under the trees. Patients are reluctant to come into the clinics because of deaths and inappropriate smoking ceremonies or not enough. So one of the clinics is actually under the trees and using some point-of-care testing equipment.
David, once your EGFR's dropped, once you've got a creatinine that's detectably raised, you've lost something like 40% of your kidney function.
Yeah, or even more. So once you're outside the normal range, you've lost half at least.
So what's the evidence that once your tests are starting, so we're saying here, we've got to do screening tests. And we're saying, okay, the screening tests come in. The screening tests are crude. There might be some more sophisticated ones coming in the years to come, but they're crude. Yeah. So if they're going to come up positive, almost half your kidney function is already gone. What's the impact of intervening then? So your blood pressure's up a little bit, and you get in hard with blood pressure, and you lose a bit of weight. Can you return your creatinine to normal?
You may not return it to normal, but at any stage of kidney impairment, you can have an effect on the rate of progression of disease with treatment, and you can reduce the cardiovascular risk.
So Leslie's working in an Aboriginal community. We're all working with people who've got busy lives. They don't know they've got kidney disease, and you want me to take major treatment. Can you promise me an effect, Beres? What do you tell your patients that I'm going to put you on these drugs, and you've got to stay on them for life? What's the promise in terms of my kidneys? What does the evidence say?
Well, I think that I suppose my first priority again is reducing cardiovascular risk. Because I think that's going to kill these people before their kidneys in many cases. So if
you've got kidney disease, do you take the same approach as diabetes? You go onto a statin regardless, you go onto an antihypertensive regardless, doesn't matter what your levels are, we're going to hit you hard for your risk factors.
That's probably summing up fairly tightly. But certainly one really has to work with the individual patient and look at the whole picture. Address the lifestyle risk factors as well as pharmacological approaches. And in some cases it really takes a bit of stepping through prioritising medications and working with patients to help them understand the targets of therapy.
Paul, what's the evidence?
Oh, there's a number of really epidemiological cohort studies that have shown the tight correlation between reductions in kidney function or EGFR and increased cardiovascular risk.
No,
there are some
but intervening.
Intervention studies, both in diabetic and non-diabetic studies, and they're usually the ones that we've looked at are looking at reductions in progression of end-stage disease, can show a halving of the rate of progression with tight blood pressure control. And predominantly it's the blood pressure control that people have looked at. As with anything, the people with the greatest risk derive the greatest benefit. So those with the worst degree of blood pressure, the worst degree of proteinuria, if you can get that under control, derive the greatest benefit, as with all things we see in medicine. So there's strong evidence that you can slow rates of progression of disease, and it probably ties into cardiovascular events as well, though most of the trials aren't powered to show that.
Got a question here, which is asking about low-protein diets. If you're starting to register high, you're coming up positive on your kidney screen, straight onto a low-protein diet?
No. In Australia, the consensus is that low-protein diets have no part to play in stopping progression of disease. There's some pockets of belief overseas where that is practiced. We certainly practice avoiding excessive protein intake, but going to a low-protein diet, the answer is no. Can I just take us back briefly to the urine testing? I would like to get across the point that conventional dipstick testing for urine protein is still okay, and it's still the area where the best evidence exists in terms of that, the importance of that in long-term outcome studies. It's cheap and it's reasonably accurate. So I don't want people to feel they shouldn't do it, but there's no question, as Paul was indicating, that we are moving progressively towards albumin as a more accurate measure, and as one which can be done in the laboratory more easily. So stand by to watch for the next 6 to 12 months. New recommendations may well be coming out in that direction.
Another online question: how does one investigate someone suspected of having chronic kidney disease? David?
Well, you did the initial screening test to prove it, so doing their EGFR and looking at their urine, as we've just said, and then the investigations that you do depend on the stage of kidney disease. So if it's very early, you may not do too much more than that.
As defined by?
By the level of GFR. So once your GFR falls below 60, so you're into stage 3 chronic kidney disease, that's when you start to look at other things such as hemoglobin to see if the patient's anemic, start to look at calcium and phosphate to see if there's imbalances there.
David, you'd also agree that if at any stage of GFR reduction, if there is proteinuria or albuminuria present, that adds greatly to the risk of progression.
Yes, you're quite right. So the GFR and the proteinuria are independent risk
factors.
factors.
And the new coding or the new staging is going to take account of proteinuria at every stage.
Yeah.
And what's the place, the viewer asks, or our online viewer asks, of renal biopsy? When do you start doing that, Paul?
Oh, I mean, it depends.
Because this goes to when the GP would actually refer on.
Look, it probably depends a bit to what school you went to, and people are changing. I must say, we do a lot less biopsies, I think, now than we used to. Most people would biopsy if there's definite nephrotic syndrome, or if maybe there's significant...
So you've got edema, proteinuria
of greater than 3 grams a day, low albumin, swelling, all the rest of it, because those diseases may benefit from specific treatment. Again, if you've got significant proteinuria, which we define as over 1 gram a day, and ACR roughly of about 100, a protein creatinine ratio of about 100, people may biopsy there looking to see if they treat with other agents other than our standard therapy, which is aggressive blood pressure lowering. There's a debate about that, and we can discuss that, but I think that's really for nephrologists. But for the majority of patients, we wouldn't be thinking of biopsy unless there's rapidly progressive loss of kidney functions with hematuria and significant proteinuria.
Let's go to our first case study. Lily is a Caucasian, or a non-Indigenous 40-year-old woman on her first visit to see you, Beres. She's coming for a checkup. She has 3 children, and she tells you that in her first pregnancy she had swollen ankles and high blood pressure. And you measure her blood pressure, and it's 160 on 90. And she tells you, oh, well, that's what all the other doctors had, got for me recently. And when you ask her, she says she doesn't smoke, and she just has 1 or 2 drinks at the weekend.
Well, certainly this lady's come for a checkup, and I'd actually clarify what her expectations are. And in the general practice setting, a checkup means a bit more than just checking a blood pressure and honing immediately in onto that issue. We'd certainly discuss other preventive health aspects, lifestyle aspects, looking at risk factors for cardiovascular disease and screening for cancers, in particular pap smear screening. But for this context, I suppose the hypertension is significant. Certainly that history of pregnancy-related hypertension will contribute to her risk of kidney disease, and she should actually also be screened at this point in time for kidney disease, particularly looking at her EGFR and at her urine test. I'd also probably want to check a little bit further regarding her blood pressure, make sure it's not due to some other cause. I'd do routine electrolytes, I'd do a full blood count on her at that point in time as well. And I'd then start certainly to address her cardiovascular risk factors also. I'd probably do her cholesterol at this point in time and fasting sugar.
What if she had blood in her urine, Tim?
Then you'd need to establish that it's persistent, and then there's an algorithm which we can distribute, but I think we're not planning to talk about tonight, which would demand investigation. Persistent, dipsticks positive hematuria is abnormal and should always be investigated.
And would you send off for microscopy on the first occasion?
Yes, you'd certainly send it for culture.
Are we still old-fashioned enough to look for casts in urine? Or?
No, casts don't get mentioned much anymore, but the presence of what we call glomerular hematuria or dysmorphic cells has replaced that, and where you've got a reliable service that does that well, that's a very useful help in determining whether the hematuria is coming from the kidneys or from the urinary tract.
Leslie Salem, I suppose in an Aboriginal, if this was an Aboriginal woman from the Aboriginal community, you'd be thinking about blood sugar.
Yes, I'd be looking at lifestyle risk or urinary tract infections if she had hematuria. Sorry, the line was going a bit blank there. I missed some of it. And I would be looking at further sampling to confirm that it was consistent hematuria and looking at her diabetes and those sort of risk factors.
And what would be the challenges here of this woman moving forward? Let's assume that she's really just beginning to show a reduced EGFR and maybe just a little bit of protein in the urine. What's the whole picture that GPs and others have got to look at?
I think you need to look at her social situation. I think a multidisciplinary team is really important. If you have a dietitian who can speak with this lady, if she needs, I don't think she smoked.
No, she's not a smoker.
No. So, and looking at her bloods and urine tests over time, and you can demonstrate to her progression or improvement of her results depending on her treatment and whether she's adhering to the treatment.
So Bears, she comes back to see you, and the only tests that will come up trumps are EGFR's down a little bit of protein in the urine, not a lot. What are you going to do now for her?
Well, certainly I'd want to control her blood pressure. She's actually a relatively young woman, and I would probably have a brief chat to a renal physician about her. I suspect that the proteinuria is related to hypertension. Certainly in controlling a hypertension, I'd use an ACE inhibitor or an ARB. I'd usually use an ACE inhibitor first. But I'd probably just have a brief discussion with a nephrologist.
Well, you've got three here. Take your pick.
I suppose the question is there anything more that I need to do for her at this point in time?
Okay, lads, fight over this patient here.
She needs an ultrasound, and she needs a proteinuria or albuminuria quantitated, and she needs to be watched over time to see what the trends are. And
so she needs an ultrasound to see if she's got an obstructive uropathy?
Yes, just to be sure you're not going to have a red face in 2 years' time. So that, but otherwise time will sort this out. If in 3 months her blood pressure is under control, her albuminuria has gone away, and her GFR is stable, then you know you're on top of things and you can just continue to manage without referral.
Let's change the story a little bit. She's 38 and she wants to have a fourth child. What are we going to tell her now, David?
Well, it depends on the level of her EGFR. So if her blood pressure is under control and her her EGFR is above 50, then probably she's going to be okay with the pregnancy, and it probably won't have much extra risk for her kidney. But once her EGFR gets lower than that, there's a risk that her renal function will get worse during the pregnancy.
And is there a risk of eclampsia?
Yeah, there is an increased risk of hypertension getting worse during the pregnancy.
What's the eclampsia story here, a preeclampsia story, Paul?
Well, she's had it in the first pregnancy with the hypertension and the swelling and so forth. Her second pregnancies, I think, were okay. And generally, if you get through the second and third without preeclampsia, it's less likely. She may well have sustained hypertension during the pregnancy and transient hypertension towards the end. It'd be unlikely she develops preeclampsia based on her previous history. The only thing to point out is she can't be on an ACE if she's wanting to get pregnant, because it's fetotoxic. So she needs to be off that agent in the first trimester. But yeah, there would be no problem with her being pregnant. She'd be at slightly increased risk. You just watch her.
And to what extent do we look for other causes of her hypertension and her kidney disease, Tim?
If the hypertension is controlled and her kidney function stable, then I would not go beyond an ultrasound.
So we'll just say it's idiopathic kidney damage. We don't know why she's got it.
Well, I mean, you may well be missing some mild nephritis, but it's not going to be treatable, so you would just treat expectantly.
So you don't go hunting hard for autoimmune kidney disease?
Well, if you think there's an underlying nephritis at some stage, if you then go to referral to a nephrologist, then most of us would do a screening for nephritis with anchors and ANFs and immunoglobulins, etc. But the yield on those is quite low.
It very much depend on the degree of her albuminuria or proteinuria. If there was lots, it wouldn't fit with simple hypertension. If it's very mild, you probably wouldn't chase it. Or if she had hematuria and proteinuria, suggesting it.
So, and as a nurse practitioner, sit back from this, take a whole view of the system. When is it appropriate if a person, if a GP does have a specialist nurse practitioner in the town, when does the nurse practitioner see a patient? When should a patient be referred to a specialist? What's the story there? Give us a sort of system-wide view from where you sit.
I get some direct referrals from GPs for people who have very mild kidney impairment, stage 2s, people that they're very worried about their diabetes, for example, or people who are becoming anemic, and I will help them manage.
So control slipping away from the GP?
I think they just they don't think it's serious enough to contact a nephrologist, because they know that the nephrology services are very busy, but I'm like an extra link that they can access, and then if I'm worried, I'll just flick them straight into the nephrologist clinic.
When do you refer on, Veris?
I think a number of people in stage 3, people with glomerular hematuria, I'd certainly want a discussion regarding them, and certainly anybody beyond stage 3, or people who've got complications.
Question here from one of our online viewers, Michael Nixon from the Northern Territory. 95% of my patients are Aboriginal and Torres Strait Islanders, and issues around diabetes, hyperlipidemia and hypertension, together with helping people understand the implications of compliance to the medication regime, are always uppermost in my mind and my interactions with patients. So in other words, taking the holistic, it's more of a comment than a question, but do you have a comment on that, Leslie? Would you concur with those views?
Absolutely, and I think that's where the nurse practitioner role has come into play in this, in that we can give longer consultations, we can go to more different areas where it may not be feasible for a GP because GPs are private practice and they need numbers and that to sustain their own business, whereas we can be employed under different methods and go into areas. We can case manage a little bit more frequently and follow people up in their own communities. And that's one of the benefits that we're able to provide, like Anne and I, and why we get referrals from GPs who may have lost a patient who hasn't followed up with them, and we can actually go and seek people out in their community. And I get referrals also from the maternity services on Aboriginal clients who really don't have a location or a GP, so I can follow them up and track them into more and work with the GP in a collaborative team arrangement. So that's a take on how we'll do it.
Let's go to our next case study. Vivian's a 46-year-old woman, non-Indigenous woman, BMI of 25.5, so she's not really overweight. She's had type 2 diabetes and been on insulin for the last 4 years. She's high blood pressure, she's got high cholesterol, and biopsy has detected diabetic nephropathy. Vivian's a single mother with a 17-year-old daughter. She works full-time as a casual, and she's a social smoker, about a pack a week, and a rare social drinker. She can't afford all her medications and wonders what meds she can miss. She's stressed and had a few hypos while exercising. And her current medications are Novorapid, Lantus, Lasix, amlodipine and atorvastatin and ramipril. Her HbA1c is 8 at the moment. Her blood pressure is 130 on 80. Her albumin-creatinine ratio is 360. Her urea is 8, creatinine's 80, and her EGFR is 71.
Well, certainly we have comparable. We have results there from previous times as well, and we can certainly see that there's been some improvement in her HbA1c, which reflects her control of her diabetes. There's certainly been some improvement in her blood pressure and some improvement in her ACR and improvement in her EGFR. Although we note on those results that her HbA1c is not yet to target and her blood pressure is also not yet to target. So there certainly is some more work to be done here, but it's good to see that improvement there.
So which of her drugs can she ditch because she can't afford them?
I actually wouldn't have immediately thought about ditching any. I probably would have to work with her fairly hard, though, to work through these issues of enabling her to convince her that we think that these are all necessary.
But she's not got type 2 diabetes. She's 46, she's not fat, and she's on insulin after she's been on insulin for 4 years. This is a woman with type 1.5, isn't it?
That's not unreasonable. I think she's a very interesting case in that she's continuing to have heavy albuminuria despite having a combination of ACE and ARB, and yet her creatinine has improved over some period of time. So there are some good things happening and some not so good things happening. I think all the drugs are essential, as Beres said, but she continues to smoke, Norman, and I think that's a major issue.
So she should save her money by giving up the cigarettes.
Absolutely.
Nice for you to say it, Doctor. I'm sure that's extremely effective advice. And how would you be approaching this? It's obviously not an easy situation for a woman living in difficult circumstances.
I think that she does need to cut down the smoking as much as possible because it's an independent risk factor for chronic kidney disease and cardiovascular disease. I think that will save her a lot of money because they're very expensive, and possibly change her to the combination poly pills that are appearing on the market now. She is very, this is the sort of lady that you can have a really good win with. This lady, we should be able to keep this lady far, far from dialysis for her whole life.
Given that she's probably not got type 2 and she's got insulin-dependent diabetes, Paul, what's the impact of better diabetes control on her kidney function?
Not as much as better blood pressure control would be what most of we nephrologists would say. So we'd focus probably on blood pressure reduction, and some recent articles suggesting...
But just pretend you're a real doctor and you actually look after more than the kidneys.
Yeah, well, again, even for her other vascular risk factors, most of this, even the UKDPS showed that the blood pressure reduction was the greater driver of improved cardiovascular outcomes, even apart from renal analysis. So we'd focus on blood pressure and try and get that down. You can rationalise the medications. I mean, we do aim to target a HbA1c of 7%, but I don't think the risk reduction is as great as with blood pressure control. I can't quote you a percentage, I just don't know, but it's not as great as across the board for all vascular risk.
Just going back to the smoking, Norman, the evidence is that if you smoke in the presence of kidney disease, you'll go on to dialysis twice as early, that is, you're half the time to dialysis as though you don't smoke. I think it's a very useful figure to use with patients.
Given that she's probably got type 1, what would you be doing about a 17-year-old daughter, David?
Well, no, I think she still does have type 2.
Do you?
Yeah, well, we're seeing type 2 diabetics at a lot earlier and earlier age.
But they're fat, and she's not fat.
No, you don't have to be fat.
She's lost weight.
Yeah.
Oh, has she?
She
Oh,
lost
very good.
weight.
Okay.
Yeah.
That was a quick save there, Dr. Matthews.
But anyway,
You'd be better off looking at waist
you brought up
circumference and BMI.
You brought up the question of her family history, and I think that's very important because she's got kidney disease, so her family is at risk of kidney disease as well, and diabetes.
So regardless of cause?
Yes, that's right, regardless of cause, but particularly with diabetes.
And if this was an Aboriginal woman, Leslie?
I guess as much as you can, looking at drugs that are on a PBS system, or looking at where you can hook into the Aboriginal S100 schemes so that it becomes affordable for them to stay on medications. Using the Aboriginal health education officers and health workers to case manage and follow and help. Really good explanation, education, ensuring the person understands the issues that are involved in their particular case. And often health literacy is just so poor in so many people, Aboriginal and non-Aboriginal.
And let's go to our next case study. Sandra is a 56-year-old Aboriginal woman. She's a bit overweight with a BMI of 27.4. She's got type 2 diabetes and is on insulin. And she's got also high blood pressure and high cholesterol levels. She's an ex-smoker and an ex-drinker. She's got lots of work to do with her family and works part-time. She really is confused about whether she's taking her pills or not and forgets to refill her scripts. And she is on insulin, Mixtard. She's on lisinopril, amlodipine, aspirin, metoprolol, caltrate, and omeprazole. Leslie, do you want to comment?
Lifestyle, you'd have to look at this lady's lifestyle changes that could be modified to start with weight, exercise, and once again I lead back into education, and it is culturally appropriate to see if she's a decision maker in her own health, on her health, whether other people help to make decisions, whether she has control over whether she gets her medications or not. And so the social dynamics of the family are really important here. But you'd be encouraging, before you do anything else, you'd be encouraging exercise, nutrition and weight loss, and looking at secondary smoking within the house as a start, as a key start with this lady, to tidy up before you even start on helping her with the medications.
Let's have a look at her pathology, Beres. Her HbA1c is 14.6. Her blood pressure is up a little bit at 128 on 85. Albumin-creatinine ratio is 880. Urea 12.1. Creatinine 197. EGFR 23. PDH 12.
With men at her blood pressure normal to 170/95.
Sorry?
With
Current blood pressure.
Oh, sorry. So I'm looking at an old measure of her blood pressure. She is still hypertensive, and we're not doing a great job about controlling her blood sugar. Your patient?
Yes, well, certainly not only is her diabetes, hypertension poorly controlled, but her renal function is also not flash. I agree with the previous comments regarding lifestyle, and certainly we've got to get those reinstated, but it's also time to actually have a chat about medications. And I think, well, one, we know that she's certainly not been getting scripts filled, but we've actually got to go back and work through the reasons for that and see if we can actually find some common ground so that we can move forward with her to encourage her to actually get her scripts filled and actually take a medication. I mean, it's difficult to go adjusting doses if you don't know what the patient's already taking. And so one really has to ascertain what's been taken lately before you even change doses.
How bad is her kidney function, David?
Well, it's bad, as we can see on her results. She's down to a quarter of normal, and if she continues in the same way, she'll need dialysis in the mid future.
So how soon?
Hard to predict, but when she gets to an EGFR of certainly less than 15, but as low as 5, depends on the individual patient, she'll be needing dialysis. So she's got a while to go, maybe a couple of years from 23.
But David, the red lights are flashing here, aren't they?
Yeah. So, there's a number of things of concern here. I mean, it looks as though her kidney function has actually improved, but in fact, what's happened is that she's not taking her blood pressure tablets, so that it's a false impression here. So she's got a higher...
Explain what's going on.
Well, she's got a higher blood pressure, so she's got more blood pumping through her kidneys at the moment.
Right, so
and
we're
she's not
squeezing through the dying kidney.
She's not taking her ACE inhibitors, so her GFR looks better than it should. Just one comment I wanted to make on her treatment. I mean, we're assuming that her poor blood pressure is due to non-compliance, but it may be also her diet. And one thing we haven't discussed in her diet is so far as salt. And certainly if she's having too much salt, that could make her blood pressure a lot more difficult to treat.
Anne?
I think it's really important that people are seen by a multidisciplinary team involving the GP, the nephrologist if they're at that stage, nursing staff, practice nurses in the GPs. Dietitians are very important because they can spend the time with people, they can actually go through them and do a food diary with them and then make very small changes. The earlier that the dietitian can see a patient, the smaller the changes that person has to make.
And are they often quite salt sensitive?
A lot of people in rural and remote communities add a lot of salt, not only Aboriginal people. They just,
Some of us don't need to live remotely to do that.
But you just see, you'll go to a barbecue in a remote place and everybody at the sausage sizzle tips the salt on before they taste anything. So it's just the habit there.
I mean, a couple of other things about blood pressure control in these people. The number of tablets you need to achieve your target blood pressure goes up as your GFR declines. So at a level of 20, you're probably on 4 or 5, sometimes even 6 medications to reach a target blood pressure. Generally, just about everybody has some salt and water retention, requires diuretics, which she's not on, but she probably does require them, would be our sort of general mantra, I guess, and probably a loop with a low GFR, although thiazides do work. And you could probably have her on some combinations that are long-acting once a day that might make it easier for her to comply rather than the twice-a-day metoprolol and other sort of drugs. So there's a few things.
So what sort of combinations would you be thinking of without giving away brand names?
You could use ACE thiazide or ACE CCB combinations. There's actually out next year there'll be an ACE thiazide CCB combination drug, and I think they'll be useful. We were talking before that the ideal would be a depot that you could inject for several months that would work, but something that's long-acting once a day, and you can mix and match combinations to make drugs easier.
Leslie, it's all very well for us pontificating here about the idealised care of someone like Sandra. How do you make it culturally effective? In a sense, how do you make it effective by being culturally sensitive, if you like, and culturally safe?
Keeping the person in their community, so visiting specialists, people who visit the areas, linking them in with that as much as you can, realising that many won't leave their community to go and seek specialist help. So getting support from as many of those teams that Anne was talking about to come to a close location or to those communities to help. And for this lady as well, you're looking at the complications of kidney disease, the anemia and the bone disease. So doing as much of the pathology or the testing within the community so that person stays with family. A lot of them have a deep fear that once they're removed from that community for treatment or help, that they don't come back.
What we haven't told you, Leslie, is that her cholesterol's up, 8.5, triglycerides 5.2, her LDL's up a little bit too. She's not anemic, one wonders why, but she's not. So she's going to need statins and maybe a fibrillator or something like that as well. I mean, this is a bundle of pills, which is hard enough for somebody who's got full control of their lives to get, much less living with all the huge demands of living in an Aboriginal community.
And that's a huge issue that we face here. One, they will not travel 100 kilometres or 200 kilometres, or they don't have transport to go and fill a prescription. Can't afford the prescriptions when they get there. So linking in with programs like we're running where we have health workers who will actually pick up the prescriptions and take them out and monitor whether that prescription is being taken. And once again, I use point of care to monitor a blood sugar level or to help the patient see the gains from taking medications. And education. And in education in a manner that is not as wordy as we see in many of the pamphlets that come out, looking at artwork or figures or language that suits a community. And there can be discrepancies between different communities.
A question here, Anne, is how aggressively do you monitor someone like this, given the controversy over monitoring, that you can over-monitor and get into a pickle because you're testing too much? We're on a slippery dip with Sandra, but how actively do you go?
I think if we're trying to keep this lady away from dialysis, she needs to be closely monitored. I would say she should come and see the endocrinology team or the renal team every month when they come over to her community. I think she needs to, the Indigenous health workers are invaluable. If you've got Indigenous health workers that she trusts that are spreading the same message that the teams are spreading, then you get continuity of that message when you're not there.
What are the different models of care that are available for Indigenous communities?
I think you need to find out what people want. I think in the past it's been very paternalistic and clinics have been built and patients don't go to them because it's not what they would have chosen or it's not where they feel safe. So I think you have to have community engagement. I think you need to bring this, I think the care does need to come to the communities because people can't afford to travel. And in a lot of cases in North Queensland, they have to fly. Could be 1,000, 2,000 kilometres to get to the nearest nephrologist or vascular surgeon. And that's a big ask for people.
A GP in Queensland asks, what's the current state of knowledge in between hemodialysis and peritoneal dialysis? What's the benefits? What are the downsides and upsides? Let's take it living in a city versus living in an Aboriginal community or living in a rural town without a lot of support. David?
I think that the choice between the two is very much up to what suits the patient. And if there's a medical contraindication to one or the other, that's obviously will guide you. But usually that's not the issue. It's usually patient choice. And if a patient is well dialysed with either peritoneal or hemodialysis, they can do equally well.
You run statewide dialysis services, Paul, in New South Wales. What's your view on this?
I'd agree with David.
The bean counters want you to do PD all the time, do they?
It's no more cost effective than home hemodialysis in our state. So there's no cost benefit to PD. And so we have it as a patient choice. But either modality has its problems. With PD it's peritonitis and infections and loss of it. And the average time on PD in Australia is 2 to 3 years is how long the modality works before people shift off to hemo on the whole. Hemodialysis, if they can do it, and it's a greater technical burden for the patients and their families to learn and to manage, but if they can do it, it has a good outcome, and the major problems are related to maintenance of vascular access. Both put a burden on the person and their carer, and in remote communities, if you're doing home hemo there, it puts a burden on the local health staff to look after these patients, and sometimes, in some places where it wasn't the territory when we set it up, there were concerns about being held responsible for health workers and that if things went wrong. So there was a degree of reluctance or fear about having home or community-based dialysis. The benefits to the patients, the community were great, but there were concerns that needed to be weighed up in those settings.
The pathway by which people finish up on peritoneal or hemodialysis is poorly understood in this country. Kidney Health Australia is just doing a national consumer or patient survey of everybody on dialysis, be it in hospital or home, trying to better understand that pathway. We're encouraging all patients who will get a form to fill it in and let us know what their pathway's been, what their feelings are, what their success is, and to help us guide this very important question of which is the preferred way.
And an online viewer asks, what are the hallmarks of a good satellite dialysis? How do you make it work remotely? Leslie, do you want to comment on that? Do you have much experience of that?
We can't ignore the patients who are in satellite units. Previous to this position, I looked after 360 patients in satellite and home dialysis. And once again, it was a focus on cardiovascular risk for these patients. So constantly looking at issues around dry weight, and their medications, timing of medications. So even though they're in satellite units, with nurse practitioner support working with the GPs in the community, you can create very stable, well patients. So very much a health promotion view of looking at patients in the satellite units is important.
David Appleton from Malakuta Medical Centre asks, what's the role of combination ACE-ARBs and at what doses?
Well, in proteinuric kidney disease, there's a role for both of them, and the combination appears to be better than one by itself. That's a little bit controversial, and in fact, if you push the dose up of an ACE inhibitor or a receptor antagonist, you can probably get as good an effect as you will from combining the two together. The main drawback, of course, is to the combination in patients with renal impairment is whether they become hyperkalemic or not. So you need to watch for that.
I mean, there's an important trial that came out earlier looking at the hypertensive vascular risk patient, the on-target trial, which showed ACE-ARB combinations had no benefit in reducing cardiovascular events and had a greater degree of adverse effects with decreased GFR and hyperkalemia. So it's only in a small group, significant proteinuric renal disease, that you might consider them. And the other thing there, I guess, is we should fess up the trial that suggested that would the combination halve the rate of progression has actually been shown to be fraudulent. So we
right.
So
Dr. Appleton, you might just want to be a little bit careful about how you're throwing around this combination.
If you're going to use that, you might want a nephrologist to be with you just in case something goes wrong. So I wouldn't use the combination routinely. And again, the most important thing is the achieved blood pressure, not the drug you use. And an ACE-ARB won't give you the degree of blood pressure lowering you get with an ACE thiazide or an ACE-CCB generally. You don't get the. So I'd go for those combinations these days.
Beres, what about the challenges of the elderly? And I suppose that could be defined in any way what you like. Since we're all approaching the elderly age group, let's be loose about the age where we define somebody as elderly. But kidney disease in the elderly, what's the story from your point of view as a GP?
Well, certainly there is an increased rate of kidney disease in the elderly. And I suppose there are two different perspectives on this. One is that really we shouldn't be ageist and we must continue to look for the condition and manage it. And the other side of it is really to have a look at the person and look at all of their comorbidities and have the discussion with them. And of course, I suppose I frame that really thinking about at what stage of CKD they're at.
Tim?
Yeah, I think the only really contentious issue is whether you consider dialysis for someone, say, in their 80s, mid-80s and beyond, which I would call elderly. Apart from that, all the treatment plans to do with hypertension and cholesterol reduction and things should, I think, apply. Certainly the evidence is now in that treating hypertension in the elderly is effective, and I don't see any reason for not offering elderly people EPO and phosphate reduction and all the things one would do for the complications. Whether you offer them dialysis is a very difficult issue, has to be considered individually. Australia offers about a quarter of the rate of dialysis to that age group as other OECD countries. So we're probably under-delivering by international standards, but you talk to a lot of Australian nephrologists and they would say, maybe we've got the balance right here, and there is recent evidence showing that if you don't offer dialysis to that population, that they tend to do about as well as those that do get dialysis.
And is age a strong enough risk factor to be a trigger for screening in its own right?
We teach that over the age of 50 is the cut point above which the risk of having kidney disease of a yield is sufficient to justify the screening. So the answer is yes.
Paul?
I'll stick with Tim on that.
Oh, you chicken.
But you might cut out at 70 or 75. I mean, there's an upper age above which...
Why would you cut it out? You've told me that you're going to have the same criteria of everybody else. You might get people an extra 4 or 5 years if you actually pick up some kidney disease and treat it aggressively.
For the same reason that the absolute risk tool was not applied above the age of 75, everyone is so high risk for everything that it justifies treatment.
Anne, do you have any comment on looking after the elderly with kidney disease, chronic kidney disease?
I think it's our growth industry, really.
This is your future we're talking about.
I think, most of the patients I see would be over 65. There's very few that would be under 50.
And Leslie, you should be so lucky that you see somebody who's elderly in an Aboriginal community.
Exactly. Two issues here. Elderly and Aboriginal is a lot younger. I mean, the median age death from CKD is 60 in Aboriginal people as opposed to 82 in non-Aboriginal. So age is relative, I guess, and a lot younger for Aboriginal people. But the important issue here with is if you identify CKD, you can link into palliation programs, which I'm not talking about end-of-life palliation, but symptom control. And there's new clinics coming on board for control of itch and control of pain and things associated with CKD. So I think it's important to identify it at any age to whether you're either going to actively dialyse them or link into appropriate palliation services to make the person comfortable.
Pain, Anne? What pain do they get?
A lot of people have quite severe arthritis, and we're telling them they can't take any of the non-steroidal anti-inflammatories.
Yep.
Panadol Osteo and glucosamine don't always do it, and so there's a lot of pain.
They get metabolic bone disorders, so if they've got high PTHs, they've got headache, bone pain, muscle aches, which goes along with all the complications of CKD.
Interesting and disturbing. What Medicare items help in all this, Eris?
Well, I think that it's really good that we...
It's one of our questions from our online viewers.
Oh, there's certainly a Medicare item numbers, and I'm probably not going to list them specifically, but there are two separate structures. One is the GP management plan, which there's a rebate for actually working with the person to clarify what the problems are, determine the goals of care, and then to determine who does what, what the patient's responsibilities are and what the GP links them into. There's also an item for reviewing the GP management plan. There are also items for team care arrangements where one actually coordinates care with other health practitioners. Most of the divisions have actually put a lot of work into supporting and teaching GPs how to use these item numbers, and I'm aware that more and more practice nurses are actually having a major role in building these management plans into general practice and helping keep the plans on track.
What about nursing item numbers?
There are, I think there's 6 for allied health. There is no Medicare provider numbers for nurse practitioners currently, but that's before the Senate.
But there are for practice nurses.
There are for practice
And
nurses,
that's
but
terribly
not nurse
important, I think,
practitioners.
in the practice of nephrology. The APNA have got teaching modules now online that the government have arranged for all the chronic diseases, and we've strongly encouraged GPs to use those item numbers to make it a business case in favour of employing practice
Employing
nurses.
a practice nurse to help with the screening and the...
And you can use, I think there's 10 visits that for follow-up with a practice nurse, so that if you put something in place like a medication, it can be followed up and blood pressure's checked, urine's checked, things like that. So there are a lot more access to numbers for follow-up after you've identified somebody.
And now, just before we finish our programme, we'll get you the results of the last question on the poll. Do you identify Aboriginal and Torres Strait Islander people? And you all do in your practice. Well done. Leslie, what's your takeaway message for viewers?
That I think initial screening and identifying problems in communities and the extent of that, and then pulling teams in to help. So getting people to visit the community or an area close to that, and linking in with Aboriginal health workers and local services, and particularly lifestyle services such as smoking cessation or exercise programs. So the team moves beyond a clinical team to an education and a lifestyle team, are very important as much as the pharmaceutical treatment.
Leslie, thanks, and thanks for staying on the line for the entire programme. It's been really good of you. Anne?
I think my take-home message would be we have to get the screening out there for the people who are at increased risk, because it is silent. There are no symptoms until up to 90% of your renal function's gone. If your your kidneys are deteriorating at the same rate as your cardiovascular system and your eyes and whatever. So if we can screen people earlier, the interventions are so much smaller to make such a big difference.
Paris?
Oh, I'm somewhat reductionist in my thinking, and I think that we really need to recognise that this is a very important cardiovascular risk factor, and it's worth looking for.
Paul?
that the declining GFR and increasing proteinuria or albuminuria independently and progressively predict vascular events and risk of renal disease. And hopefully we'll give you one way of thinking about albuminuria/proteinuria in the next year or two, Tim, so that people know better how to assess and use it as a clinical tool.
Tim?
The number of patients on dialysis in this country has doubled in the last 9 years and is destined to double again in the next 10 years. The only way that Kidney Health Australia thinks that's going to change is by finding kidney disease earlier and doing something appropriate about it. It is silent, and therefore we must go looking for it.
David?
That it's definitely harmful, but it's also preventable and treatable.
Thank you all very much indeed. An illuminating programme, and I hope you found it too. Chronic kidney disease, a silent condition. If you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation website, rhef.com.au. Don't forget to complete and send in your evaluation forms and register for CBD points by completing the attendance sheet. I'm Norman Swan. From all of us, good night.